should say. Welcome once again to IVF Journal Club live stream. Of course, this time around, welcome once again as, of course, we are featured, of course, specialist Dr. Oybek Rostomov, fertility specialist practicing in Adore Fertility Brisbane. This evening, Dr. Oybek will talk about a research paper about fresh versus, should I say, there you go. The title of this research paper actually is Fresh versus Frozen Embryos for Infertility in PCOS. So, ladies and gentlemen, without further ado, let's welcome, of course, right now, Dr. Oybek Rostomov.
Thanks, Jesse. Good evening, everyone. Thanks for watching this live stream or watching the video later on. So we will continue to yesterday's conversation. Yesterday, we presented a paper on fresh versus frozen embryo transfer in ovulatory patients. And now we are presenting the second paper published by the same group, which actually looked at the fresh versus frozen embryo transfer on PCOS patients. So this presentation has two parts. First part, we will present actually the paper, and the second part, we do critical appraisal. Okay, so let us kick off presenting the paper. So this research study was conducted in China, in Shandong region. So it was led by the scientists based on Shandong Provincial Hospital. So the study period was from May 2013 to June 2014. It took exactly 1 year to recruit and complete the study. And 14 regional IVF clinics in Shandong region participated in the study. So most importantly, let us establish inclusion criteria. So they actually studied population of women between the age of 20 to 34 years of age with a history of polycystic ovarian syndrome, which was defined according to Rotterdam criteria, and who were undergoing first cycle of their IVF. So anyone which didn't fall in this category were not included in this study. Okay, so now let us look at the study protocol and the interventions. So patients who may meet this criteria were recruited for the study, and they had the antagonist regime in terms of ovarian stimulation, and they started Gonal-F 112.5 units if they were less than 60 kilograms. Anyone more than 60 kilograms had 150 units of Gonal-F. And also it was also the clinicians could adjust the dose by adding additional menopur. In terms of pituitary down regulation, they had the tetratyte from once leading follicle was 12 millimeters. So, and once leading follicles was 18 millimeters or larger, the patients had a HCG trigger. After 36 to 36 hours after the HCG, they had egg pickup procedure. So, okay, so then randomization. So randomization took place after the egg pickup procedure. So all patients were randomized except those who did not meet the criteria for exclusion. So any patient who had less than 3 eggs or more than 30 eggs were excluded from the study. Less than 3 eggs because these patients have a less likelihood of having viable embryos for the transfer, and they were not included in the study. And very importantly, patients who had more than 30 oocytes were excluded from this study. So essentially, patients who were at risk of OHSS were excluded because they felt that they should not have a fresh embryo transfer if they were at risk of ovarian hyperstimulation syndrome. Okay, so 762 patients were allocated to fresh transfer group. This was a control group. Then treatment arm was a frozen embryo transfer group. 746 patients were allocated. Okay, so patients who were allocated to fresh embryo transfer group had their embryos checked on day 2 or day 3. If they had less than 3 embryos, let us say less than 3 eggs fertilized, they had a assessment of embryo on day 2. If they had more than 3 embryos, they had assessment of embryos on day 3. and 2 or less than 2 embryos were transferred. Actually, more than 90% of patients had a double embryo transfer, which is same in frozen embryo transfer group. So let us say the embryos were checked on day 2 or day 3, and two top quality, best quality embryos were transferred, and the remaining embryos were frozen. So in the group which were allocated to frozen transfer treatment arm, again they had 2 embryos. They had the embryos assessed on day 3, and 2 embryos were frozen. Two top grade base quality embryos were frozen, and the remaining embryos were cultured then frozen. Okay, so the patients who were allocated to fresh group had a progesterone injection. So it was actually an intramuscular progesterone injection, 80 milligrams IM daily from the next day of egg pickup. And if they got pregnant, the progesterone was continued until 10 weeks of gestation. The patients who were allocated to frozen group waited for about 4 weeks. So they missed one menstrual cycle after the fresh egg pickup. With the next cycle, they started frozen embryo transfer cycle. And all frozen embryo transfer cycles were done on HRT frozen cycle using estradiol in form of Proguanova. Then a luteal phase support. Once endometrium reached 8 millimeters or so, they had a luteal phase support using, again, same progesterone injection as in fresh cycle, which is 80 milligrams IM daily injection. And if a patient got pregnant, the progesterone was continued until 10 weeks of gestation. So this was interventions. So in terms of adherence to protocol, out of 762 patients in fresh group, 680 patients adhered to the protocol, which is approximately 90% adhered to the protocol. 82 patients, which is about 10% of patients, either withdrew from the study or had a protocol deviation. So which is very comparable in other group. In frozen group, 658 patients adhered to the protocol out of 746, which is 11% of the study population in that arm. And the 88 or 11% withdrew from the study or had a protocol deviation. So it is sometimes not possible to avoid protocol deviation in randomized controlled trials. So the protocol deviation should be less than 20%. So here the protocol deviation is fairly minimal compared to general RCTs. So 10% had a protocol deviation, which is fairly acceptable. And most importantly, we will see later. So the study used intention to treat analysis, which means even if patients deviated from the protocol, they were analyzed in the group which they were allocated. Let us say a lot of patients from fresh group decided that they want to do frozen transfer, and they were actually analyzed in that group, irrespective whether they had a frozen transfer, and vice versa. This is actually most reliable method of analysis, which is intention to treat, ITT. Yeah. So now let us look at the result outcome of the study. So when we discuss outcome of the study, we are mainly interested on primary outcome, which is live birth. They investigate a number of secondary outcomes. Yes, we can discuss, but we are not that much interested on those because study was powered to study primary outcome, live birth. It wasn't powered to study additional outcomes like ovarian hyperstimulation syndrome, preeclampsia, any other miscarriage, or any other additional outcomes. That's why we are going to focus on primary outcome, which is live birth. So the patients who were allocated to fresh embryo transfer group had a 42% live birth. Patients allocated on frozen to the frozen embryo transfer group had 49%, 9.3% live birth, which was higher than fresh cycle. And study reported that among infertile women with polycystic ovary syndrome, frozen embryo transfer was associated with higher rate of live birth. So essentially, they found actually in patients with PCOS, if you do frozen transfer, you get more babies, higher rate of live births. So, and they found that rate ratio was 1.17. So yeah, essentially they're saying close to 20%, 70% more babies you can get if you do frozen transfer. So validity of this claim we will analyze when we're doing CASP analysis. Okay, so
All right, thank you so much, Doc, for that one. And again, ladies and gentlemen, that was, of course, the research paper on fresh versus frozen embryos for infertility in PCOS. Now, at this point, of course, just like what we did yesterday, definitely, of course, we're going to go through the critical appraisal, wherein, of course, we'll be using the CASP from UK. And mainly Dr. Roybeck will be doing this critical appraisal of this research. And for everybody's information, it is the process of carefully and systematically examining research to judge its trustworthiness and its value and relevance in a particular context. Critical appraisal is essential to combat information overload and identify papers that are clinically relevant. Some issues or aspects needed to be considered when appraising a randomized controlled trial or RCT are its validity, methods, and of course results. So there you have it. Now, of course, let's move on with our critical appraisal. First question that I'd like to ask you, Doc, of course, under validity is, did the study address a clearly focused research question?
yes, I think they did because the focus of research question was very focused, which is comparing fresh versus frozen transfer in PCOS patients. It's very defined question, and also they defined the population, intervention, and comparator and outcome measures. Yes, answer to this question is yes.
Thank you so much. Considering as well, of course, if what the study was designed to assess the outcomes of an intervention and those things under that. Now, next question for the validity is, was the assignment of participants to interventions randomized?
Yes, so it was a truly randomized controlled trial. Randomization took place by the randomization team, and actually the assessor did not directly get involved in the randomization process, so it was independent. Yes, so the yes answer to this question is yes.
Thank you, Doc. Now, one more under validity. Were all the participants who entered the study accounted for at its conclusion?
Yes, because they gave this chart and where they said 1,500 patients underwent randomization, and this is allocation of patients into two different arms, and they accounted for all patients who actually completed the protocol, and they accounted for all patients who who discontinued or changed the protocol. So each individual patients um, um, and the patient's intervention is clearly defined. And also they said one patient was lost to follow-up in fresh arm and four patients were lost to follow-up in frozen arm, and they actually reported exact number of patients who were lost to follow-up. And answer to this question is yes. Actually, we covered all three questions of validity, and we believe this
Mhm.
is valid, and we can continue analyzing the methods of the study.
All right, moving on with the methods, starting with blinding, of course. Were the participants blind to intervention when they were given?
Uh, they were not because it was impossible because the participants, which are patients, had to know whether they're doing fresh transfer or frozen transfer. Answer is no, but that's a valid method.
All right, thank you, Doc. Now, next one is, were the investigators blind to the intervention they were giving to participants?
No, they were not. Again, investigators had to know who's been allocated to fresh transfer or frozen transfer because the patients had to complete those interventions, and doing dummy transfer would be unethical. That's why I think this is valid method, and they were not actually
All
blind.
right, thank you so much, Doc. Now, next one is, were the people assessing and analyzing outcomes blinded?
I cannot tell. Actually, the paper and I also looked at the protocol. I couldn't find information. They might have been, but
Mhm.
I couldn't find this information. I can't tell. And ideally, they should have been blinded because it was uh, technically possible.
Thank you, Doc. Now, last one also, another question for the methods. Were the study groups similar at the start of the randomized controlled trial?
As yes, they were. They reported this chart characteristics of patients at the baseline, which is at the time of randomization. So this is a frozen arm, and this is a fresh arm. You can see that main determining factor, for example, age is exactly the same, 28 years of age on both group, BMI and fertility history, and cause of infertility, fertility history. Yeah, so all the lab parameters, antral follicle count were very comparable.
All right, thank you so much, Doc. Now, next question here that we have is, apart from the experimental intervention, did each study group receive the same level of care?
Yes, they did. Looking at the map, we can see that they had the exact same intervention coming up to the randomization process when they had, which took place when at the time of egg pickup. So only difference in intervention was fresh transfer and frozen transfer. Most importantly, actually, in both fresh and frozen arm, the embryos were checked on day 2 or day 3, and the embryos which were going to be transferred, if they were in frozen arm, were frozen on day 3, and those embryos were transferred. For example, they did actually froze some embryos for that arm in on blastocysts, but they used embryos with frozen, chosen, most importantly, chosen on day 3. So yes, only difference in intervention was fresh or frozen transfer.
Thank you. Thank you so much, Doc. Now, this time let's move on with the results questions. Were the effects of intervention reported comprehensively?
Yeah, effective intervention was reported very comprehensively. So they reported outcome of each, of course, primary outcome, which is life birth, and outcome of secondary outcomes also reported, like OHSS and preeclampsia and premature labor. So the reporting was quite thorough. So in terms of analysis, we discussed it was intention to treat ITT. That's the most valid way of analyzing for patients who actually switched the interventions. And in terms of power calculation, so I have maybe criticism. I think that the one of the weakness of any RCT in reproductive medicine, in most fields of research, is most fields of research in medicine is RCTs are usually underpowered. Not all, of course, and most RCTs are usually underpowered because it's so difficult and so resource intensive to get enough sufficiently powered RCTs, including in this study. For example, this RCT was powered for 80%, had 80% power, and for significance level 0.01, which is good. And they actually wanted to detect 10% difference, like yesterday's paper, 10% difference in change in live birth rate in absolute terms. So they said, okay, if in fresh transfer we are getting 30% live births, if we do frozen transfer, which is intervention, we can increase live births from 30% to 40%. That's a really big jump. Like we discussed yesterday in IVF, interventions do not make such a significant jump. Let's say in IVF we have thousands of different interventions. Even if each intervention increase live births by 1 or 2%, would have very high success rate in IVF. Usually, this effect size is very small with any intervention, because IVF is multifactorial treatment. In effect of individual factors is small. So when you have such a big effect size, achieve such a big effect size, then you need a less number of patients. Like here, so they said, okay, if you want to jump from 30 to 40% with 80% power, then we need only 530 patients, which is just over 1,000 patients. In other end of spectrum, most powered RCT specifically in this question would be to seek small effect size, which is, let us say, we are assuming frozen transfer intervention increases success, not 10%, only 5%, from 30% to 35%, which would be more realistic. So, which means you need more patients, and power also from 80% to 90%. 80% is minimal power you want, and if you want 90% power, then you need 5,218 patients. compared to 1,000 patients. You need actually 5 times more patients to have a very powerful study with significant power in this research question. So then you may settle, okay, 5,000 is unfeasible. So let us settle in the middle. If you want to settle in the middle, then you can reduce the statistic significance level to 0.05. And then again, still you will need 3,684 patients, so which is 3.5 times more. So comparing to this parameters, this study was fairly underpowered, which of course can cause type 2 error, which means there may be difference, you may not find difference. So yeah, so overall I think the intervention reported comprehensively, the answer is yes, but with one caveat, the power of the study was very weak.
I see. Thank you so much, Doc, for explaining that further. Now, next question that we have here is actually, was the precision of the estimate of the intervention or treatment effect reported?
Yes, it was reported. They reported confidence interval here, so that yes, precision was reported.
Thank you. And lastly, we have one last question under results. Do the benefits of the experimental intervention outweigh the harms and, of course, the cost?
Yeah, yes. So essentially, intervention here was a frozen embryo transfer, and frozen embryo transfer was found to have a high success rate. And yes, they didn't do cost effectiveness analysis, but overall, if you look at the big picture, they did very clear reporting on primary and secondary outcomes, risk of miscarriages and preeclampsia, premature labor, in addition to live birth. So overall, it was reported very well and very well. But because they didn't fulfill this criteria of CASP, which actually requires to do cost-effective analysis, so they didn't do that. That's why I'm just saying can't tell. Yeah, so overall, this is final findings. In terms of validity, let us assess validity of the study. Yes, the study is very valid. Answer is yes to validity questions. So methods, they were very appropriate and they're fairly robust, except the criticism is power of the study, and the results were reported clearly. So yeah. So now let us decide whether we are going to keep this study in our library and use in our clinical practice, or we are going to bin this study because it is not valid. So after above assessment, we decided that we are going to keep this research paper and use in our clinical practice. However, we have to be aware that this study is underpowered, and on its own, we can use it, but still we have to have additional research evidence on effectiveness of frozen embryo transfer compared to fresh embryo transfer.
All right. There you go. Thank you so much, Doc, for that. And that's IVF Journal Club on fresh versus frozen embryos, of course, for infertility in PCOS with Dr. Oybek Rostomov. And to everyone, please go ahead and check out all our social media pages and our website, rostomov.com.au, for more information. Doc, please invite them once again for Saturday, if I'm not mistaken, for Saturday's live stream. What will they look forward to?
Yes, yeah, we will continue the journal club, and we are aiming to complete all RCTs, all randomized controlled trials, which looked at the fresh versus frozen embryo transfer. Then, we have covered this research question, which says whether frozen transfer is better than fresh transfer. So, yeah, I think there are about 5-6 different RCTs. We'll cover all, and then we can move on to different research questions. In terms of IVF, live stream steps of IVF, live stream on IVF steps, we will be continuing those live streams as well. Thanks everyone for joining today's live stream. I wish you a great day ahead, and we will catch you next time. Thank you.
Thank you once again, Doc, and see you all again this Saturday for another exciting discussion. Please join us again for another episode of the live stream with Dr. Oybek Rostomov. Thank you, everybody. Enjoy your evening.